musculoskeletal system, section 4, will discuss the crystal-induced arthropathy, systemic lupus erythematosus, Sjogren's syndrome, and scleroderma. Under the crystal-induced arthropathy, we'll talk about gouty arthritis, pseudogout, and calcium oxalate arthropathy. This is the classic presentation of gouty arthritis with the basically presenting in a patient who has a severe episode of pain and tenderness, maybe redness in the right big toe. Actually, it's painful to touch, and maybe similar episodes in the past, and for sure this is the classic presentation of the, where is the sodium urate crystal deposition. So basically it's not uric acid deposition, it's sodium urate crystals deposition. And that's the main reason for the gout, which is monosodium urate crystal in the joint, seen in patients with hyperuricemia. And remember that gout is associated with some other conditions. Some of them are not very common, like Lesch-Nyhan syndrome. And that's not very common condition, but it's classically presenting with the hyperuricemia and gouty arthritis, glucose 6-phosphate dehydrogenase deficiency with increased production of uric acid, and under excretion of uric acid. It's not just overproduction of uric acid, but it could be associated with under excretion of uric acid. Question. Your patient has been started on antihypertensive medication. Few days later, he developed an episode of gouty arthritis. What is the medicine? That's hydrochlorothiazide, and can cause under excretion of uric acid and precipitate the episode. Most probably is going to be the patient who has history of gouty arthritis. Here is something that I want you to remember for the sake of the exam and for your practice. Uric acid, when it is precipitating, is going to be like having the needle-shaped negative birefringent, as opposed to the pseudogout, which is rhomboid. That's the pseudogout with the rhomboid shape, positively birefringent under polarized light microscopy. Both of them has to be visualized under the polarized light microscopy. This is one of my patients with the needle-shaped. It is a very obvious needle-shaped of the sodium urate under polarized microscopy. Why I put this dog here, Croatian or Dalmatian? Anyone has one of these dogs? No? Yeah, I'm going to tell you why. Because actually, the only two mammals that might get gouty arthritis are human and this dog. Not all the dogs, actually. The Croatian is the only one, okay? And the human. And the reason for this is not for a veterinary lecture, but for human medicine. I'm going to tell you why. Because in our body, like this dog, we don't have urate oxidase enzyme. So the end result of the metabolism of the protein in our body will end up with the uric acid. But all the mammals have urate oxidase enzyme, which is able to change uric acid into allantoin. And allantoin is very safe. It's going to be excreted in the urine without precipitation in the joints, and it doesn't cause gouty arthritis. And we have a pharmacology question on this. I'm going to tell you about it in a minute. So what do you mean by tophi? Uric acid deposition under the skin can cause nodules. This is a couple of my patients with the tophi under the skin, which is full of chalky white material, can induce some sort of local inflammation and pain. Okay, that's the tophi in gouty arthritis. Which of the following type of arthritis is associated with hemochromatosis? Which one? Yep, that's right. That's the pseudogout. And I want to remind you with the pseudogout that due to calcium pyrophosphate deposition associated with gout itself can increase the risk for pseudogout. Hemochromatosis and hyperparathyroidism are commonly checked, and high yield Wilson disease, hypothyroidism, but remember hemochromatosis, hyperparathyroidism associated with pseudogout. And the most common site for gouty arthritis is the big toe. The most common site for pseudogout is the knee. And how do you diagnose this? Joint aspiration. You will see inflammatory fluid and look for the rhomboid shaped that we talked about it before, this shaped positively birefringent crystals. They might try to trick you that the patient never had previous episode of gouty arthritis. You checked his uric acid for some reason and it's a little bit elevated. Are you going to start the treatment for this patient? The answer is no. Because the treatment of asymptomatic patient who never had episode of gouty arthritis and elevated uric acid is not an indication for the treatment. However, if the patient has one episode of gouty arthritis, now his uric acid is high, we have to treat this, okay? This is something that I want you to remember, which is the chondrocalcinosis, which is calcification or deposition of the pyrophosphate calcium or calcium pyrophosphate in the joints, particularly in the cartilage. And that's why we call it chondrocalcinosis, and usually associated with pseudogout, like 95% of the patients. The treatment of the pseudogout is NSAIDs, or you might give the patient some corticosteroids or oral corticosteroids. What about the calcium oxalate arthropathy? For the sake of the exam, that's going to be a patient who is on hemodialysis, acute inflammatory arthritis, and the crystals are large, red, and bipyramidal. Look at this, like two pyramids connected to each other. So calcium oxalate arthropathy is hemodialysis patient complaining of acute kind of inflammatory arthritis. You draw some of the fluids. What are you going to see under microscopy? Bipyramidal crystals, which are large and red in color. Okay? Hemodialysis patient. Here is the pharmacology of gout. If you have a patient with acute episode, you might give anti-inflammatory. The one that we usually use it a lot is indomethacin, or you start the patient on colchicine. I don't think that they will give you both of them on the same answer choice, okay? But if there is something obvious, like they give you the choices including both and tell you which one of this medication can cause diarrhea or something like that, so you know that this is the one that you are not going to use. Or you might say, they might say, which medicine are you going to start with, and keeping in mind that you avoid diarrhea. So they put both of them so you avoid the colchicine and give the indomethacin, okay? Colchicine, you will get some information in regard of this medicine in the cell biology, because it does work by inhibiting tubulin polymerization and microtubular formation, like the cytoskeleton of the cell in leukocytes, reducing neutrophil chemotaxis and immigration, okay? So let me tell you about something regarding the acute episodes of gouty arthritis. Actually, the presence of the crystals in the joints is not the primary reason for arthritis. So if you have a patient with sodium urate crystals, which it looks under microscope, under the polarized light microscopy very sharp, So you get the impression this kind of crystals like causing the pain. It is not primarily the cause of the pain. These crystals might stay for years in the joints of the patient and nothing is going on until our polymorph nuclear leukocytes, for some unknown reason, started to attack these crystals, engulf the crystals, inducing inflammatory kind of reaction, okay? So the problem is the action of the leukocytes. That's why the use of colchicine in this situation will prevent, look at this, will reduce neutrophil chemotaxis and immigration. So as long as we keep the leukocytes away of the site of this kind of crystals and prevent them from engulfing the crystals, the acute episode will not gonna happen. So that's the mechanism of action of colchicine. We need to know this. And for sure, I'm sure everyone here knows that colchicine can cause diarrhea. That's terrible side effect. What about indomethacin before we leave this? If they tell you your patient has history of severe GI bleeding, are you gonna give NSAIDs? No, we try to avoid this. You might select the colchicine. It will not gonna cause GI bleeding, okay? What is the other alternative? Could be oral corticosteroids for acute episode of gouty arthritis in someone who's unable to tolerate colchicine, and he's not a good candidate for NSAIDs. The other kind of question that's going to be a little bit more complicated, if they give you the labs of this patient and tell you creatinine is 2.8, and the patient is unable to tolerate colchicine, are you going to give this patient NSAIDs? No, because the kidney function is not good. They will make it more complicated. They will tell you the patient is in the hospital and he has continuous vomiting. So we are unable to give the patient something by mouth. What is going to be your treatment? You give the patient corticosteroid intra-articular. So I blocked all the doors for you. The patient has elevated creatinine. The patient is vomiting, unable to tolerate colchicine. The only thing that we can do is intra-articular injection of corticosteroids, okay? So just keep in mind all these choices, because it could be just a couple of line question and you don't know what is going on, just intra-articular corticosteroid injection. What about the chronic gout? What do you mean by chronic gout? Chronic gout means the patient has couple of episodes of gouty arthritis. Now he doesn't have any redness or swelling in his joints, but his uric acid is elevated. What are you going to do? You give something like allopurinol that will inhibit the xanthine oxidase enzyme that will block the conversion of hypoxanthine and xanthine into uric acid. One of the other medication is a propenicid, which will inhibit reabsorption of uric acid in the renal tubule. So we are fighting in this situation to prevent the high level of uric acid. So that's what I'm telling you, diarrhea is the problem with the colchicine. The metabolic complications of cancer treatment can cause what we call a tumor lysis syndrome. So just keep this in mind. I put it here. It is not gouty arthritis. It is someone who has different problem, but going to induce very high level of uric acid. What is it? Tumor lysis syndrome. What is the tumor lysis syndrome? You treated one of the patients with one of the highly metabolic kind of malignancy, such as lymphoma, Burkitt's tumor, or leukemia, or they give you any example of this kind of hematologic malignancy, and they will tell you the patient started on chemotherapy, then his uric acid is very high, hyperuricemia, high phosphate, hyperpotassiemia, renal failure. Why this patient is going to develop renal failure? And that's one of the serious problems like hyperkalemia. Hyperkalemia, the patient might die from cardiac arrest in diastole. Calcium hypercalcemia, the patient is going to die from cardiac arrest in systole. Okay? So the problem here is the deposition of uric acid in the renal tubules, and that can cause, look at this, obstructive acute renal failure. So that's obstruction of the distal tubules and collecting duct due to precipitation of the uric acid crystals. Remember that the distal tubules and collecting ducts will have the lowest pH, so urine alkalinization and hydration before starting the treatment will reduce the risk. Again, the question will be, your patient's going to get chemotherapy tomorrow for one of this highly active malignancy. What should you do? Give allopurinol to the patient as a prophylactic measure to prevent tumor lysis syndrome. This clear? So what is the problem with the tumor lysis syndrome? Two main things: electrolyte imbalance and excessive uric acid in the blood. What is going to happen with the excessive uric acid is going to deposit it in the distal tubules and collecting duct, causing obstructive uropathy. The patient will develop kidney failure due to obstructive uropathy. The other problem is electrolyte imbalance, particularly hyperpotassiemia, and the patient might die with cardiac arrest. How do you prevent? Give allopurinol before chemotherapy. If the patient has nausea and vomiting, he's in the hospital, ready for chemotherapy tomorrow morning, you're supposed to give the patient allopurinol, and allopurinol is an oral medicine. What are you going to do? Look at this. Give urate oxidase enzyme, and that will transform the uric acid into allantoin. What do you call it? Rasburicase. What is the rasburicase? Rasburicase is the enzyme that we don't have it. And Croatian dogs don't have it. So give it to the patient because he has nausea and vomiting, and that can be given intramuscular or subcutaneous. So give it to the patient instead of the allopurinol. That's a good pharmacology question because they will ask you about the mechanism, and now we know what is the mechanism. Allopurinol is very good. It's going to work on the, what is the enzyme that is going to work on it? Xanthine and hypoxanthine. And oxidase is going to be prevented or inhibited by allopurinol. The patient has nausea and vomiting. Give urate oxidase enzyme that will transform excessive or high level of uric acid into allantoin and will prevent the development of acute kidney failure. This clear? 35-year-old male has facial rash mainly in the nasolabial fold and has arthralgia and positive ANA test. What is the most likely diagnosis of this patient? What is the most likely diagnosis? Lupus. Look at this. No, it is not lupus. You know why? Because I'm telling you in the question that this is not lupus. Why? In fact, when they give you a picture and you want to know that this patient has lupus or not, look at the nasolabial fold. If the nasolabial fold is involved, this is never be lupus. It has to be clear. So nasolabial fold has to be clear. Number two, you don't have the criteria for lupus. Number one, nasolabial fold is involved, so that's not lupus. You have just some arthralgia and positive ANA, and you need actually 4 out of this 11 criteria for the diagnosis of lupus. Is this clear? So the hint for the sake of the exam. They will give you most of the time patient with actinic keratosis on his face. Or give you young lady and they will tell you that she has positive ANA and she has acne. Why? Because that's going to be affecting the nasolabial fold. But the butterfly never involved with this area. So look at it. Look at this area on the exam. If it is involved, forget about it. This is not lupus. So this is the malar rash, discoid, photosensitivity, oral ulceration, or arthritis, or serositis. We talked about this in I remember we talked about, yes, pericarditis in cardiology before. And I told you that the cardiovascular problem in systemic lupus is mainly pericarditis, if you remember. And renal involvement, talk about it forever. That's the cause of death in most of these patients, okay? The neurologic disorder, psychosis is common, so it might be a little bit of like distracting symptom when they provide psychosis in young female with a little bit of symptoms of lupus, and you might say, you don't look, for the differential and you include lupus because of psychosis. In fact, it is very important, and it could be something you will distract you on the right answer on the exam. You know what is the other condition that it's going to be presenting with psychosis on the exam? That's going to be Wilson disease. Wilson disease of the liver. They always ask you about middle-aged female. She's brought to the ER by her friend with psychotic problem and give you a little hint that she has liver problem. This is Wilson disease, okay? So that's the tricks on presentation of lupus. For sure, I'm going to tell you about the diagnosis, which kind of serology. We'll talk about anti-Smith. We'll talk about anti-double-stranded DNA and all these things. And the what about the anti-phospholipid antibodies? And what about the anti-phospholipid syndrome and ANA? The last thing that I put here is ANA, which is very sensitive, but it is very non-specific. Okay. So here is the patient. Look at the nasolabial fold. It's very clear. 47-year-old white male presented with rash associated with fever, weight loss, polyarthropathy, and he has white blood cell count, leukopenia, hemoglobin is low, platelets low, urine analysis, 3+ protein, few red cells. So 3+ protein means nephrotic syndrome. So we have a lot of criteria. Butterfly rash, nasal and Miller, alopecia. Actually, alopecia, you will see alopecia in systemic lupus. You will see alopecia. You know what is the other patient that might have alopecia on the exam other than idiopathic alopecia? The patient with the stomach problem, vitamin B12 deficiency. What do you call this condition? Pernicious anemia. So remember, the patient was the alopecia. Patient was the vitiligo as well. Most probably is going to be the pernicious anemia. Photosensitivity, more common in young female and more aggressive in African American. Symmetric arthritis, but the arthritis in systemic lupus is not deforming. It's going to be some sort of pain, maybe some swelling, but it's not deformity. Raynaud's phenomena is common. Lupus nephritis, a lot of types, and wire loop lesion due to capillary thickening, renal failure, that's common cause of this. And remember, subendothelial deposits is something that they usually ask about it when we come to the renal problems with the lupus. I'm going to tell you about it. False positive VDRL due to antiphospholipid antibodies. So the antiphospholipid antibodies will interrupt the test in the lab, and that will produce positive, false positive VDRL. Okay? So the question is, do you think that this patient have syphilis? No, they don't have syphilis. They just have false positive VDRL. Cardiac anomalies, pericarditis, as we talked about it before, maybe myocarditis, congestive heart failure, coronary vasculitis, and might induce angina or even MI. The other cardiovascular problem that you see in systemic lupus is Lippmann-Sachs endocarditis, which is non-infectious. We talked about it before in cardiovascular diseases, vegetations involving the cardiac valve on both sides. I'm sure that you remember this. We talked about it before, and may manifest in a similar way of infectious endocarditis. What about the pulmonary problems with the systemic lupus, fibrosis, and pulmonary hypertension? Neurologic symptoms, seizures, strokes. What else that might be? Psychological problem, psychosis. That could be with the systemic lupus. So detail the patient is in the emergency room with very obvious signs of a stroke. The patient is 34 years old, African American. Give you a little hint about systemic lupus. They ask you about is the reason. The reason is neurologic manifestations of systemic lupus, which is inflammatory kind of reaction in the cerebral vessels. It's not the classic presentation of stroke. The patient doesn't have history of coronary artery disease, no diabetes, and no history of smoking. Hematologic disorders in lupus, anemia, that's very generic. We know there's going to be anemia of chronic disease because that's a chronic disease. And again, hemolysis might be seen in these patients because of the formation of anti-red blood cell antibodies. Leukopenia, look at this, more specifically lymphopenia. So this could be a good question. Lymphopenia is specifically seen in patients with lupus. Low complement, particularly with disease activities, and I'm going to tell you about this again in the next few minutes. Thrombocytopenia, because antibodies, not just for the red blood cells, but for the platelets, and it can cause thrombocytopenia. Let me ask you, Coombs test is going to be positive or negative in this condition? It's going to be positive. Any case with antibody involved, hematologically, Coombs test is positive, okay? The recurrent thrombosis, miscarriage, and usually seen in patients with antiphospholipid syndrome, and antiphospholipid syndrome commonly associated with systemic lupus. But we have primary antiphospholipid syndrome. What does it mean? Patients with just antiphospholipid syndrome, and they don't have systemic lupus. For the pathogenesis of lupus, it's an autoimmune disease associated with the formation of polyclonal antibodies. Could be immunoglobulin G, M, or A against the nuclear antigens. That's why we have the anti-nuclear antibody, okay? Remember that these antibodies bind to antigens to form immune complex, will activate the complement if it is immunoglobulin G or M, and this activation might cause microvascular inflammation and tissue destruction. So that's the pathogenesis that we need to remember. Which type of hypersensitivity? That's very obvious that this is type 3 because of the complex and the activation of the complement. What is the other conditions that's commonly asked about type 3? Autoimmune, polyarthritis nodosum, post-infectious glomerulonephritis is type 3 hypersensitivity reactions, all of them. Okay. What is the most specific antibody test you could order to make the diagnosis? What does it mean? You have your patient in the clinic, you suspect systemic lupus with some of the criteria. Then what is the test that you need to order? And it should be very specific. Which one? We have two very specific serology tests. Number one is anti-nuclear antibody. Is that right? No, that's wrong answer. That's wrong. Double-stranded DNA, and what is the other one? Anti-Smith. Okay, so these are the two. Let me see. Yeah, anti-double-stranded DNA and anti-Smith. What is the anti-smooth muscle antibody? I put it here because I don't want you to be tricked with this. We have anti-Smith antibody, and we have anti-smooth muscle antibody. Anti-smooth muscle antibody is seen in patients with autoimmune hepatitis. Anti-smooth muscle antibody. But anti-Smith is very specific for lupus with the anti-double-stranded DNA. What is the most sensitive but not most specific? That's ANA, okay? So ANA sensitivity, 90%. What about specificity? Very poor. Anti-double-stranded DNA and anti-Smith antibodies are 100% specific for systemic lupus, but the sensitivity is 60% for anti-double-stranded DNA, 25% for anti-Smith antibody, respectively. The anti-histone antibody, that's a drug-induced lupus, and I'm sure that you know these things. And why I put this in bold letters, I'm going to tell you. We know the big list of drug-induced, the classic, which you most probably get couple of questions. Hydralazine, procainamide, quinidine, methyl-dopa, all these things is the classic. However, we added doxycycline, we added the tumor necrosis alpha blockers such as infliximab, because we have been using this medicine a lot in in many of the autoimmune diseases right now, and we found that they will tell you the patient started on biological treatment for something like rheumatoid arthritis. Now he has some rash on his face and he has arthritis. What are you going to do? Order the antihistone antibody, and that's a drug-induced lupus. Okay? Don't check the single-stranded DNA. It has no clinical significance. It could be distractor on the exam. Single-stranded DNA.